Good afternoon. My name is Dr. Jason Koh, and I'm the Mark Neiman Family Chair of Orthopedic Surgery at North Shore University Health System, and also a clinical professor at the University of Chicago, and an adjunct professor of biomedical engineering at Northwestern University, as well as vice president of the Patellofemoral Foundation. It's a tremendous honor to be invited to speak here, and I want to thank Professor Abdel Hamed for his incredible work as the president of EGAA. Professor Amal Abdelaziz, the past president, and of course Dr. Mohammed Kamal Morsi, who's organizing this amazing Congress. I'm here speaking in behalf of the Arthroscopy Association of North America as an international ambassador. The Arthroscopy Association is the leading voice for education, surgical skills training, and assessment related to arthroscopy and minimally invasive surgery, and the vision it has is to be a global leader driving innovation and optimal care. There are actually over 5,500 members from 77 different countries, and it's a truly international community. And we work in collaboration with outstanding organizations such as EGAA, committed to improving patient outcomes. There's actually 14 organizations that ANA partners with, and there are four international meetings where ANA faculty will speak this year, and we're very appreciative of the opportunity to partner with EGA. There are 17 corporate partners with ANA as well. So ANA shares information to help patients across the world. This is my good friend Pietro Tonino, who actually spoke, and this was the meeting in 2020, EGAA, and I know that there's been a close relationship between EGAA and ANA, and we want to continue to foster and encourage that. There's an opportunity for international membership in ANA, which provides continuing education, both live and online courses, discounted registration for different meetings, including specialty day and the annual meetings and lab courses. There is a free subscription to the Green Journal, the Arthroscopy Journal, and also access to member-only scientific and technical resources, and scholarships and grants. And so ANA actually gives away thousands of dollars a year in scholarships, and so we encourage you to be a part of this and contribute to your work for submission. Access 5,500 peers across the globe, and there are a number of international members on committees and actually holding office in this international organization. The annual dues are $150. You can log into ana.org and join if you'd like. So these are my disclosures. In many cases with patella instability, NPFL is good, but this case, there are certainly situations where more needs to be done, and several of those have been described already. This was a patient with a tibial growth arrest when she was a child and had significant patella baja, and she actually had to have a proximalization tubercle osteotomy, which is very unusual. The indications for tibial tubercle osteotomy are instability with alta or severe malalignment. Others are to unload the articular cartilage, and sometimes for extensor mechanism contracture or other damage. We'll start with patella alta. Patella height is typically calculated by different measurements of the articular surface or the length of the patella related to the height above the tubercle or the tibial plateau. And most instances will consider distalization if it's more than a 1.4 ratio. Functionally with patella alta, there is a longer time period before the patella is captured by the bony trochlea. In these situations, the NPFL is less isometric, especially when that ratio is greater than 1.6. So an NPFL reconstruction does not provide as much stability as it does in a normal situation. And there are several papers indicating that with patella alta, that there can be an extremely high failure rate if this is not addressed at the time of NPFL reconstruction, up to 37%. Typically, with our goal of distalization is to get a ratio of about 1.2, which is high normal, not try to correct it to 1.0. We've done finite element analysis, and we've demonstrated that distalization reduces maltracking, increases stability, and also can reduce mean contact pressure because the contact pressure in patients with patella alta is significantly abnormal. Another situation where you may consider tibial tubercle transfer is a lateralized tibial tubercle. Historically, we've used the anterior tibial tubercle to trochlear groove distance. although there is significant variability in measurement. In general, we think about greater than 15 millimeters is abnormal, and greater than 20 millimeters is significantly abnormal and may need to be corrected. MRI distances are relatively similar, although can underestimate. Again, with a lateralized tibial tubercle, the MPFL is more anisymmetric, and so a standard MPFL reconstruction may not work as well. Some papers feel that there's not a significant benefit for tibial tubercle osteotomy, but in most of those situations, the TTTG was 20 or less. And most experts in the patellofemoral study group, of which I'm the treasurer, indicate that the excessively lateralized tubercle does need a tubercle osteotomy. It decreases cartilage overload and does improve Kojala, Lysholm, IKDC, and J signs, and in large database studies shows that there's a decreased risk of reoperation. In general, when we try to make these corrections, we're trying to reduce the TTTG to about 15 millimeters, not 10. A third indication for tibial tubercle osteotomy is articular cartilage unloading. One of the preferred techniques in the United States is the Fulkerson oblique anterior medialization osteotomy. This is an anterior medialization of the tubercle, and the amount of change can be determined by changing the angle of the cut. If the cut is angled more vertically, then it shifts the load proximally and more anteriorizes the tubercle, or it can be done a more flat medial cut where the load is shifted more medially. Unloading of the articular cartilage lesion unloads the distal and lateral facet of the patella or lateral trochlea. It doesn't work as well for central, diffuse, or proximal lesions, and you may want to have a more anteriorization procedure. The workup for these tubercle osteotomies, if you're concerned about articular cartilage, is to get an MRI if possible, or a previous arthroscopy. Typically, anterior medialization works well with distal lateral patella lesions or lateral trochlea lesions. So I'll briefly go through some of the technique, the arthroscopic evaluation. You evaluate the articular cartilage and tracking. This is a patient where there is significant lateral facet damage. I make a midline skin incision and define the medial lateral borders of the tubercle and the patella tendon, and open the anterolateral fascia and elevate the musculature. I've been doing this sometimes with electrocautery directly off the bone. You want to avoid going deep to the septum and coagulate the small perforators at the proximal edge of the osteotomy. You can make a small incision. I would recommend starting with a longer incision, but you can define the medial and lateral borders. My preferred tibial tubercle osteotomy technique is a Fulkerson type for both instability and unloading. It's one I'm very used to. In this case, the shingle is larger and less likely to fracture than some of the other tibial tubercle osteotomy techniques, which can be very short. In general, I try to make a shingle length that's relatively long, 5 centimeters. If there's significant anteriorization, I may make a longer shingle of 7 centimeters. The angle of the cut is more vertical and more anterior. If you make the cut more vertical, then it will be more anteriorized. I typically taper the osteotomy, leaving the tip distally intact if possible. I use a small saw and irrigation and soft tissue protection. So you can see I'm using a relatively smaller saw. Sometimes you can actually use a cutting guide of the blade of a retractor that's flat, so you can make the incision relatively more precise. Proximally, I finish the osteotomy using curved osteotomes. You can see the shingle here is about 5 centimeters in length, and I do provisional fixation with a K-wire, measuring the amount of translation as preoperatively templated. Again, arthroscopically evaluate the tracking. Fixation of the tibial tubercle. Various techniques have been described. If you use 2 3.5 cortical screws, the strength of this is probably around 1100 or 1200 newtons. You can use more screws, 3 screws. Typically, I make the screw tracks divergent and aiming somewhat more distal with increased stability. If the patient is obese, muscular, non-compliant, or the distal hinge is disrupted, such as when you're doing a distalization, then I will typically use 3 screws. Initially, I used 4.5 millimeter screws. but these had a high rate of removal because the screw head was symptomatic. And so I have switched to 3.5 millimeter screws that are countersunk, and I'll place this in a lag fashion. Distalization has had several techniques described. My osteotomy that I prefer is a variation of the Fulkerson, where there's a tapered osteotomy. I want to avoid a distal vertical cut at the osteotomy tip. Some people prefer to make a very vertical cut in the distal tibia, but I'm concerned that that creates a significant stress riser in the tibial cortex. If you transfer and distalize, if you resect the distal bone at the tip, you can use that to graft proximally, and that increases the stability. And I will use 3 screws. Neurovascular risk can be significant. The structures are proximate to the posterior cortex, and you may want to look at your MRI preoperatively to see the location of the tibial artery. There is a variant where the tibial artery is directly against the posterior cortex in about 2 to 3% of patients, as opposed to having muscle in between. I typically will flex the knee to 90 degrees, avoid compressing the posterior soft tissue, and very careful perforation of the posterior cortex. So I've over-drilled the shingle. You can see that it's held in place provisionally with a K-wire, and then placing the screw. And so my goal with the screw is that this is a bicortical screw. In terms of closure and rehabilitation, I leave the fascia open. I do early range of motion using CPM if possible. Patella mobilization, partial weight bearing until 6 to 8 weeks because there's an increased risk of stress fractures if you early weight bear. But I do encourage mobilization as soon as possible. Some caveats or concerns are to avoid over-medialization of the tubercle. You want to assess patella tracking. Typically, the patella normally starts lateral and then goes medial. If it goes straight down the middle or starts medial, then that's over-medialized. Again, make sure that you are careful drilling posteriorly because of the neurovascular structures and avoid early weight bearing. The risk of non-union of the tuberosity is relatively small if the distal hinge is intact. We allow progression of activity, and typically it will take about 6 months to return to full sports. There may be some extensor lag for 6 to 8 months. In patients where you're doing an unloading osteotomy, there may be some progression of patellofemoral arthritis requiring further surgery. In most cases, the results are fairly durable. The combined results with articular cartilage transplantation may improve the results of the osteotomy, but there's not been a very clear demonstration that adding cartilage procedures is superior to just the osteotomy alone. The results, multiple authors have presented good results. Recently, 31 patients at 4.4 years, only 1 redislocation. There was 1 patient that had a tip fracture and 2 hardware removal. John Fulkerson had 93% good to excellent results at 5 years. Jim Bradley from Pittsburgh found that the 97% of athletes were able to return to sport without recurrence of patella instability. Complications are relatively uncommon. Non-union is relatively uncommon, about 3.7%. This you may have delayed union in obese patients. A detached shingle, when you distalize, for example, the increased rate of non-union is up to 10.7%. And in these situations, if there is a detached shingle, I will use 3 screws. Shingle fracture for Fulkerson osteotomies has only been reported in 1 case by Andy Kosgaria. There's a higher risk with smaller fragment. This was a patient referred to me where you can see that this was a relatively flat Elmsey type osteotomy, and the shingle fractured and moved proximally. This patient was also very heavy, about 140 kilos. Other situations, there's a risk of proximal tibia fractures with Fulkerson osteotomy, but these are associated with early weight bearings or a fall. Overall, the complication rate of tubercle osteotomies is relatively low, 4.6%, with major complications about 3%. This is a situation where there's over-medialization, and you can see the knee, when flexed, actually translates laterally because the patella has been and the tubercle have been over-medialized. And the treatment for this is revision tibial tubercle osteotomy with lateralization. So in general, I do tubercle realignment when there's chondral damage.